Good evening, everyone. Tonight we do have an interesting discussion about breaking bad news with Dr. Mohsen Abdelaal. And whenever you're ready.
Okay, hello guys, and good evening. Thank you for attending the teaching today. I just want to be sure that you can see my screen now.
Yes.
Yeah, we see it.
My name is Mohsen Abdelaal. I'm a specialty doctor in critical care at Lancashire Teaching Hospitals. And the topic that we're going to discuss today is the spikes of breaking bad news. And you will know about what the meaning of spikes shortly. So the objectives for the session today is how to conduct a consultation that the aim for it will be breaking a bad news. And to help you with that, we will be using spikes module, and I'll explain this in details later on. There is also something important about practicing medicine in the UK. What do people want to know about death? And when you face a situation where you're having a dying patient, what do the beloved ones want to know during the situation? Another thing also which is related to difficult consultations and communication with patients or relatives is how to deal with a family member or a patient who is angry. And then finally, a few tips about how to look after yourself. So I just want to share with you or to ask a question. What do you think is a bad news? And if you're happy, you can just raise hand or type in the chat box, or you can tell us what do you think is a bad news?
I would say, yes, I can tell you anything that's considered as a threatening life is a bad news for the patient. Anything that put him or his life at threatening is a bad news. Anything irreversible is a bad news. Anything that is untreatable is a bad news. Yeah, and for sure this is a bad news.
Yeah. Any other ideas? What might be considered as a bad news?
I think in our practice, usually it's a life-changing diagnosis we deliver to the patient that will affect how they are living their life.
Exactly. Yeah, so the reason why I'm asking is just to highlight to you that, yeah, devastating events are bad news, but something that you might think is just as simple. I will just discuss with this patient that he has diabetes, and I don't consider this as a bad news. It's really a bad news, and it's a very bad news, because you ask him that you have diabetes, you have to stick with a lifestyle, you have to stick with a bill for the rest of your life, and you are prone to so many risk factors. So it's still a bad news. Even if you told me, like, today I have headache and you booked me a CT in a month and you told me you can't drive until we get your CT results, this is a bad news for me. So that's the maybe an appropriate definition of the bad news, which is any information that has a negative impact on the person's life or well-being, and put under this anything that you can think whether it will affect his life, of course, or his lifestyle, or his work, relationships, or his health, this is considered a bad news. So basically, as a medical practitioner, you will be facing breaking bad news every single day in your clinic. If you are telling the patient that this diagnosis is going to change your life, or this diagnosis will stop you from doing that, or you are prone to complications because of this diagnosis. So think about it and just have a wide vision about the bad news that can be delivered to the patient. It's not only things that related to death and life. And these are a few examples, like diagnosis of serious illness, permanent change of lifestyle, or of course the loss of a loved one. So why do we think breaking bad news skill is important? Part of it, as I said, you'll be facing it almost every single day in your medical practice. And the other thing is, it's one of the biggest challenges that you'll be facing. And to be honest, most of us, if not all of us, will be happy to avoid this kind of conversations. Because it's not pleasant. It's not pleasant at all. It's very challenging, and it really put us under a huge stress. The other thing why training breaking bad news skill is important, because it's a skill. It's not a talent. So everybody can learn and practice and be taught how to break bad news. It's not a talent that we are born with, and yeah, I'm good in breaking bad news and you are not good. Everybody can be good at breaking bad news. And this is the main idea about this presentation. Another thing also, which is mainly related to us as IMGs, I don't think any of us had a proper communication training during your medical school or even your postgraduate training program. I don't think, I've never seen it in Egypt happening anywhere, that we have teaching about communication skills. Here in the UK, I'm not sure about all the medical schools, but I've seen this in Manchester Medical School. They use Spikes protocol to teach students how to break bad news, and I think it starts from year 3. So what does Spikes stand for? Spikes is a 6 steps that you'll be following during your conversation that will help you go through this without putting much burden in your brain and your emotions, and conduct this conversation in a professional way. So S stands for setting up the conversation plus listening, but it's mainly setting up the conversation. P is check the perception of the condition and its seriousness with the patient or the relatives. Then I is the invitation process. You'll invite them that you are going to discuss something which is not pleasant and see how ready they are to have this bad news. Then you will start to give the information, which is the knowledge. And then you have to deal with the emotions and the expressions that they will be experiencing as much as you can. And then the final part is the summary and the strategy for what we are going to do next. And we're going to speak about each one of them in brief. So setting up the conversation, it's a very essential part of conducting this consultation smoothly. Preparation is really essential. You have to prepare the time, the place, and the amount of information, and the whole team members. All this should be ready before you start your consultation with the patient or the relatives. So prepare yourself first. You have to know all the information about what I'm going to tell the patient, even if you are telling them that this is an end-of-life situation, you have to have the whole information that led to this at the end. You have to go through the notes, prepare yourself well, and be ready for the question that you will be facing. All team members should be on the same page. Be sure that nobody will come a few hours later and tell you, no, what the information you have said, we think about something else. Be sure that everybody is on the same page. Choose the right time and the right place. And the right place is mean that some area which probably all of us will have a relatives area or a interview room. It should be quiet. You should have privacy, maintain confidentiality, no interruptions. Your mobile phone should be silent. If you have a bleep, just hand it to somebody else. Free yourself for the next 15 or 30 minutes just for this consultation. When you are there with the family or the patient, you have to sit at the same level, maintain eye contact, be confident about the information that you're gonna tell, and use your body language, like body gestures and whatever as appropriate, based on the culture of the patient and the relatives. If you have if you have team members attending with you, you should allow the time for everybody to introduce himself, or you can introduce them if you're familiar, and allow the family also to introduce themselves. In so many situations, you might be facing so many family members, so it's very, very important before starting the conversation to assign somebody who will be the first point of contact. And again, here in the UK, this might be easier because everybody will know his next of kin, and then this will be your target. You don't have to run this sensitive discussion every now and then for each family member. Then the next step, after you start, you'll do your introductions, and then the first thing you do, you have to check how much information the patient or the relatives know, because you will start from the point they end at. You will know how much they know. Are they fully on board and aware about how serious the situation is, or nobody have updated them before and they know nothing? If they have the information, or they are aware about the prognosis, I mean, are they expecting what you are going to tell them at this situation, or you have to prepare them from the early beginning? And during this few minutes, you just be listening, actively listening and cautiously listening to the information that you'll be taking from them. And not just listening, it's just scanning the areas of mismatch and the gaps that you will be working on the next step. And again, take care of your body language and maintain eye contact with everybody in the room. And again, as I said, if you have a huge amount of family members around, try to figure out what are the family dynamics, which one of them are so close to the patient, which one of them you will be targeting with the information, because it's not comfortable to be repeating all these things with each individual in the room. So invitation, I will just keep you on track because I know it's so much information. So I have finished the setting up the consultation and the logistics around it, and I've checked the knowledge that the relatives of the patient know, and on the third step about the invitation. Oh, sorry. So part of the invitation that you will ask the patient how much they would like to know about the diagnosis or the news, because some of them will tell you I need to know every single bit of it. Others would say I'm not ready for this now, so just give me the end results or the summary or whatever. And you can use one of these phrases like I've mentioned here. Are you the sort of person who would like to know everything about what's going on, or would you like me to summarize things for you? and then you can take it from there and carry on with your consultation. And of course, if you are discussing things with the next of kin or a family member, be sure that you have gained the consent from the patient. And then here you will start. If you've noticed the last 3 steps, you didn't say anything, you're just listening or preparing. Here is your start point. It's now your turn to speak. In bad news, usually it's a good practice that you start with a warning shot to gain the attention of the patient or family, and also it helps you to gradually deliver the information and give them the time to take it in. You can use one of these. First, if this same situation, you can say, I've got your test results and it's not a good news, I'm afraid, and then you will grab his attention or her attention, and then you can go on with the results explanation. When you're delivering the bad news, you have to deliver it very clearly in simple terms. If it's death, it's death. Don't try to make it easier or looks more nice, or it's not going to be nice at all. So if the patient has died, tell them, I'm really sorry, I have a very bad news for you. Your patient has just passed away. Don't try to run around it. It doesn't help. It doesn't help. Believe me, it doesn't help. Be clear and deliver the information at the earliest. Of course, avoid any confusing medical terms. Try to be simple. You don't have to explain. If you're explaining a serious diagnosis, you don't have to go through the physiology and pathophysiology and histology and anatomy and all these things. Be as simple as you can. And you can ask these questions to check how what's the level of understanding the person you are facing. So you can ask, have you heard about this and that? Would you like to know more about this and that? And this will help you at what level should my information be. Using silence is really important, because it will help the person you are delivering information to take in this information and process it. And also if there is some sort of emotions, they will give him the time to express this. And also give you a bit of a break, because I know it's really a stressful job. It's not easy at all. So use silence cautiously, but it's really a very important tool. Then you can ask again if they want to know more details, and you can fill the gaps or summarize everything. If you feel like, no, they are not on board at all, I need to get the story from the early beginning, do that. It will help you to deliver the news at the end. And there is something which is called chunks and check. Divide the information into pieces, deliver a piece, pause, check understanding, deliver the other, and so on till the end of your consultation. Then exploring emotions and the empathy. As I said earlier, silence will allow emotions to be expressed. Please do not interrupt these emotions. Give the time for it. It's really important for the relatives or for the patients. Just listen. At this moment, the most thing that the person will need is somebody to listen to him, rather than giving him more information about it. Just give him the time to provoke the strong emotions they had. You don't have to react and do anything. Don't try to jump into solutions so early. Just be quiet, listen to their emotions, appreciate this, and be empathetic. It's also good to be familiar with the stages of grief, which I've mentioned here. Denial, anger, bargaining, depression, and acceptance. These, we might have another session to explain these in details and put a plan or a strategy how to deal with the patients who are passing through these stages. It's not a stepwise stage. You might give a bad news to a patient who just accepted. Another one will start with denial and they'll be angry and start bargaining with you and be depressed and then accept it at the end. So it's different from person to another. But it's good that you be aware about these, be ready and have a strategy how to deal with the patient if he's expressing one of these stages. Use touch if it is appropriate, and you have to be responsive. I mean, yeah, you're silent and listening, but you're actively listening, and you're telling the patient, you have my full ears, I'm really understanding. And you can say one of these phrases like, I can see this news has made you shocked, or I can say that you're angry about this news, I'm really sorry that I have to deliver you this bad news. All these simple phrases will break the ice and make things a bit smoother. The final stage will be the strategy and summary, and probably in most situations summary will be appropriate if you're breaking a bad news, especially if it's like a serious illness or a death of a beloved one. Summary won't be appropriate in these stages, but if you're delivering some kind of a news about a diagnosis and you feel like the patient is ready to have a summary, you can summarize them. Allow the time for them to ask question, offer help, tell the patient or the family, we are here just for you, we are around, you have our attention, you can ask questions at any time, you can tell the nurse, she will get to us, we can get the answers for you. Just be supportive. It's really important that you can go through this consultation smoothly. If the news has something to do with a plan, like a treatment or more investigations, you can just split the plan or the strategy into 3 parts. Now we're going to do this. Next, you will come to us to do that, and in between, this will be the plan. Like if the patient came with headache and the CT did show a mass and it's probably a brain tumor, you have breaking the bad news, but then you have to tell the patient what are we going to do for that. So you'll tell him, now you will go home, you don't have to stay in hospital, we will give you some painkillers, if he has seizures or whatever, you start him on treatment, and then the next step will be we have to do more investigation about this by an MRI in the next 2 weeks or so. In between, if you have any changes in symptoms, or if you have the pain is not well controlled, speak to the GP or speak with a specialist nurse, give him a contact, and this should be a safety netting, as they are used to call it. As I said earlier, death is one of the biggest issues related to breaking bad news, and it's really important to know these few principles, which are found the principles of a good death according to the debate of the Age, Health and Care Study Group. It's some sort of a study that has been done. They mentioned the principles about what does it mean of a good death, and this will help you to go through delivering the bad news of death of a patient to the family, and then how you will take the family through this grief process and offer them the support. Usually people would like to have the death a bit controlled and that to be expected. They don't like at all to give them a call in the middle of the night before any previous update and tell them, oh, I'm sorry, your beloved has died. This is really annoying, and it's of course it's stressful for everybody. But try to avoid this as much as you can. Whenever you have a sick patient that you are worried about, give the family a ring. Tell them that we are in this situation. I'm really concerned about your patient. He's not having a good night, and I'm really worried about him, and I will keep you updated. They want to be able to, as I said, retain the control of what happens. So they might not be upset about him dying, but they will be very upset if they haven't been involved early. Dignity and privacy is really, really important. So they wouldn't be happy with you jumping on the chest of a patient trying to resuscitate him while their main concern is having a peaceful death in dignity and privacy. So think about it, really think about it. Control of pain and symptoms. This is almost the only question I will have when I'm explaining to the family that your family member is dying. The first question they will say, is he in pain? So be sure about that. Any patient who is in agony in the ward, don't leave it like that. Don't just simply say, oh, we have tried everything and he's still in pain. It's not acceptable at all. You can refer to the palliative care team, you can refer to the pain team, you can refer to your consultant. He's dying. He shouldn't be suffering in his last minutes. There's something that the choice of the place of death, at home, elsewhere, it might be different in our cultures, I know, but here in the UK, as I said, they want to have this event under control. To have access to information and expertise of whatever kind is necessary. This is again about updating them regularly, and to feel like the whole team is with you and they will take you through this bad experience and offer the full support for you in the bereavement process. Offer any spiritual or emotional support, like access to a priest or an imam. This is really important. Some of the patients would like to have their death in a hospice or any other place at home apart from the hospital. Others would prefer to stay in hospital, so do offer the support about that. The final minutes, saying goodbye, is really important. So if you think that this patient is dying in the next few hours, call the family immediately, ask them, this is the chance for you to come and say goodbye, and invite any of the family members that you would like to be present in this situation. They will really appreciate that. If you did every single bit from the medical point of view, try to save the patient's life, and he died before you managed to give the family time with him, they will be really upset. And also be sure about that, because I have seen this is a practice nowadays for so many people who are just practicing defensive medicine. People are intelligent. People do have access to Google. They can read, they can know the prognosis about the disease, maybe in a better way than so many doctors. So there is no point at all prolonging the support for no meaningful reason. Be honest. If you think that the patient will go through this event and get back to his baseline, okay, well and good. Explain to the family that I'm still optimistic, but prolonging for just prolonging, nobody will accept it, even the non-medical people and the families and everybody. I didn't accept it for my family as well, so you shouldn't accept it for any of your patients. This is again one of the most important thing that it will make us more anxious. You know, the problem with the breaking bad news that you think, oh, the patient or the family member might get angry, and this is a strategy how to deal with an angry patient or a relative. These are the signs that you can recognize that the person in front of you is getting angry. Sorry. So the speech might become louder or quicker, or might become quiet. So be aware about that. Quiet people are not all the time nice. The facial expressions, you will pick it up. You are a professional, you pick it up. You will know that the person in front of you is getting angry. Body language getting more closed in, or suddenly has an expansion movements. Be aware. And I've put safety first at the last bit, but actually should be the first bit. Your safety is really important. So if you think that this person is a threat, don't carry on. Do not carry on. Ask for help immediately. How to approach, if you feel like it's appropriate to carry on the consultation, this is a very good strategy that you can use. Trying to explain to the patient who is angry, or the relative who is angry, that you are not right. It's the wrong to do that, or it's wrong to be angry. It's gonna make it worse. Be with him in the same boat. Appreciate his anger. He's angry for a reason. He's not just angry of you, he's angry for a reason. You have to explore the reason. And the first thing to help you to explore the reason is to appreciate his anger. Tell him, I really, really understand you're angry and I appreciate it. And we just need to discuss and say, why are you angry? So I can help you with that. Don't try to confront the patient or the family member who is angry. It's just putting fuel on fire. Establish the connection first by appreciating and understanding the situation. Allow them to express the reason, and then at this time you can jump in with the solutions. Don't try to jump in with the solutions so early. It's not also it won't be helpful. And just put in your mind, the patient is angry, it's not you, and don't take it personally. I know it's not easy to do, it's easy to say, but if you just think about it, he is just angry about the system, he's just angry about the situation, he's not angry about me, and it's not personal. And I shouldn't be dragged into anger as well. And finally, this is really, really important, guys, that you have to look after yourself. These situations never been a pleasure or easy to handle at all. It's really stressful. It's really putting a big burden on your shoulder, and never ever finish a consultation like this and run to the next patient. No, take a break, have a drink. If you feel like you're really, really emotionally drained, speak with a colleague, go out and smell fresh air. Just look after yourself, because if you're keeping doing this from one patient to the other, you can easily dragged into mental health issues, which nobody wants to it to happen. And I've put a link at the end of the presentation from the BMA. They have put really useful stuff that you can use to look after yourself. I hope you enjoyed the session. It's really a good one that you can go through every now and then. It will help you to understand the people in front of you, and it will help you also use the tools to go with these situations smoothly. And ideally, we used to do it in practice in simulation things, and hopefully maybe one day, if anybody needs to do this as a part of the exams or as a part of practice, I'll be happy to help with that. Any questions, please?
Thank you, Mohsen, for the
Thank you very much for that. It was very precious teaching session. Breaking bad news, the core competency, we should be able to master it, and we all being exposed to it like almost every day. And I've seen breaking bad news, it's like excellent. I've seen consultations with patients, families, that withdrawal of care, and that patient will pass away in hours. And I've seen also conversation which was horrible. I would discuss it, and it's a very important skill, and I really appreciate your description of it as a skill. It's not a talent. You can, it doesn't matter how bad you are, you can still learn. And I just want to mention one of the things that my consultant taught me last year. He's an ICU consultant. He told me, like, because he was a medical director of the trust before, and he told me like 50% of the complaints they receive from families about patients' care, it's just about communication. So
that's really, really true.
Yeah, so you
I've been told that in the GMC as well.
Yeah, so communication is the essential thing. You will do your best as a doctor anyway, but you still have not everyone is focused on communication with the family, but families and patients, communication is the most important thing here.
That's really true, Omar, and I would invite everybody who didn't have any communication courses or training before. It's the time. You are here in the UK. They have loads of courses and resources about communication skills that you can have access to. And yeah, as Omar said, it's one of the first things that you need to learn before practicing in the UK. Thank you for comment. Any other comments, guys? Any other questions before we sum up and close?
I just want to share our experience here, that we, as a surgeon, we have always breaking this bad news in the clinic. So it is also always a clinic situation with a time slot of 15 minutes. You should finish this breaking bad news very quickly, absorb all the patient's emotions and everything within 15 minutes, which is sometimes very difficult to achieve. So we have always a specialized nurse in the cancer nurse. I can say they specialized and attending the clinic with you, helping you with the breaking bad news. You only deliver the bad news to the patients, give him do your best, and then leave the patients with the nurse to give him the more details about the contact further, and so on. So I think the role of somebody to help you is very important in breaking bad news. If you have limited time, so you need somebody to help you to do the job. It also very supportive to the patient to have somebody else to talk about the details and things that he may be not asking you, or have need time to think about what details he needs more to know about. So yeah, so one of your colleagues or somebody else will be with you. It will be a great idea.
Just be cautious, Ahmed, about it, because many times when we face patients in their last days in ICU, after being through clinics for ages, 10, 15 years, the first thing they will do when we sit with them and explain what's happening, you know what they will say? It's the first time to sit with the doctor and explain to us what's happening. And I've heard this 2 weeks ago.
Oh my God.
It's really important to consider. Yeah, the specialist nurse, I'm not undermining her or him or anything. It's part of the system, and they wouldn't blame you. But I feel like it's not good practice at all. You should speak with your patient. You should speak with your patient.
Yeah.
15 minutes.
Yeah,
it took me 30 minutes to explain the whole process, but it can take you 10 minutes to sit with the patient. And even
no, I don't say that you leave the job to the specialized nurse at all. No. I mean that you break the bad news, tell the patients all the details, absorb the patient's emotion and so. But some patients, difficult patient, I can say, or some patients with anger, and the type of characters of patients differs from one to other. Some patients take only 10 minutes to break the bad news, and others need some time, and if you are running out of time, it will be difficult for you.
You might even need to the next session to explain it in details. I know that you are so strained about time and tight, but just be aware about it. You don't have to sit with the patient every single time, but at least give the patient your time. It's really
I understand your point, but
I think we lost Ahmed.
Ahmed, we cannot hear you.
Want somebody to help you with this? Yeah.
It's always we always deliver this consultation as a team. It's not a one-man show. It will be either me and a consultant and the nurse looking after the patient, maybe more, maybe less, but it's always a team job to do. Okay, thank you everybody for attending, and I will over to Mahmoud to close up.
Yeah. Thank you, Mohsen, for this interesting discussion. Thank you guys for attending. Don't forget to fill in the feedbacks. It will be sent shorter today or tomorrow. Have a nice day.
Yeah.
Thank you very much.
Thanks, guys. Bye.
Thank you very much. Thank you. Bye bye.
Thank you.
There you go.